Hello, hi. This is Felice again, live from Great Ormond Street in London, and I'm going to present um, a paper and a consensus statement that I'm going to present also at the European Society of Neuroradiology annual meeting in Lisbon, September 2022. And I think it's very, very important because this is a white paper written by the Consensus for Magnetic Resonance Protocol Study Group, that is an international group whose aim was and is to standardize as much as possible the MRI protocols for head and neck pathologies in children. Of course, all the other lectures are on my YouTube channel, and please feel free to send me an email if you have any questions. So to start with, I want to start with a typical case on a typical morning in a typical reporting room. This is a young lady which was previously operated for Ewing sarcoma and came to Great Ormond Street for follow-up. Now, you see, this was a relapsing Ewing as imaged in this brain MRI back in September 2014. Then afterwards, in November 2014, this was the scan we had. Two different institutions, because of course these patients sometimes have scan in the district general hospital close to where they live. Sometimes they go in a tertiary hospital and so on. And you can see these are the actually I selected the most comparable sequences, and you can see striking differences. So this is a scan of the brain. This is a flare coronal. This is a scan of the face with post-contrast FATSAT T1 as opposed to a normal T1 post-contrast. And this is a coronal stir of the orbit. Now, it is possible to compare. We do that every time, also different scans, but the typical radiology report conclusion will sound like that. This phrase that I hate is allowing for technical differences between the scan, no convincing changes are noted. Now, this is the typical conclusion, and this is the typical clinician expression when reading it, because they don't know what to do with that. So standardization is critical. So let's pause and reflect on what does it mean to have standardized protocol, and how a perfect protocol, that of course doesn't exist, but how a potentially perfect protocol on MRI look like. Well, for sure, it needs to be standardized as much as possible, but also efficient. So we need different protocol for different group of diseases or different anatomical regions, because as I will show you in a bit, they have different challenges. Also, needs to be a good protocol needs to be easily reproducible, i.e. needs to be done in district general hospital or big tertiary center with much more advanced techniques. Needs to be flexible because every patient is slightly different, and most importantly, it needs to be written by experts and endorsed by experts. So we need to find the best people around to have their specific expertise for specific region of the head and neck and specific techniques. And this is what we started with. So identify the expert, and I will have an oral communication just to show the methodology of writing this consensus, as in general, a consensus statement. But as you can see, we had a lot of authors, and most importantly, we had the endorsement of several important scientific society, either Pediatric Radiology Society, Head and Neck Society, Neuroradiology Society, and the ERIC is the retinoblastoma international study group. So what we wanted to do is actually make sure that nothing got missed in sense of expertise. And then we gave us some basic rules. So what are the rules? So this is one of my favorite movies, Fight Club, with a lot of cool rules. But as far as the protocol paper is concerned, what are the rules? Well, first of all, the fat. The fat can be your friend and your enemy, and differently from the brain, the head and neck region is full of fat. So how we manage the presence of fat, how we use the fat as our friends rather than our enemy? Well, this is a typical example. We change slightly the sequences from the brain. Look at this lesion. This is a venous malformation here, and this is a T2 stir. All the fat around the lesion is saturated. Why? Because a mass will be hyperintense in T2 and will be normally hypointense in T1, and most of the cases will enhance. So where we are looking for a tumor or a vascular malformation, we need to basically get rid of the fat around the mass when the mass is bright, i.e. having a T2 pre-contrast with fat-saturated sequences like STEER or SPEAR or SPARE. But the fat is your friend in T1, because in T1 the mass will be hypointense, and we can use the fat as passive contrast around the mass. So we do T1 pre without fat saturation. And in most of the cases, the consensus statement decide that the best post-contrast will be with fat saturation. Again, we can see precisely the patchy enhancement in this case around the mass. So the first rule is that T2 fat saturated, T1 pre normal, T1 post contrast with fat saturation. But also look at this mass. In this case, the presence of T1 pre contrast will show us the fat inside the mass. Okay, so another pearl is to look for the T1 hyperintensity of the fat in the mass, because a mixed solidocystic mass with fat content is basically pathognomonic for a teratoma. Look at this other case. This is orbit, and look how this enlargement, pathological inflammatory enlargement of the medial rectus will be very well visualized in pre-contrast T1, surrounded by the orbital fat, but also in post-contrast fat-saturated T1, where we get rid of the fat hyperintense signal. Otherwise, the brightness of the contrast-enhancing lesion will be masked by the hyperintensity of the fat, okay? And this is an example of a proposed orbital protocol. So again, T2 with fat suppression, T1 pre-normal, post-contrast with fat suppression. And I also stress the importance here of optional sequences. I said before that the goal of the consensus statement was to have sequences that are standardized but also flexible, which looks like a contradiction, but is really not, because you can add some optional sequence that can be added if you need. For instance, look at this large mass full of vessels in infant. Okay, so now if there are a lot of vessels, you need to exclude a vascular tumor and that can benefit from the angiography, but also an AVM, because if you have an hemangioma full of vessel, it will probably regress over time, while an AVM, arteriovenous malformation, will need actually an operation. And what you do then? You can do an MRA, so MR angiography, that shows no AV shunt demonstrated in this case. So you can confirm that this was an hemangioma, and it's very, very important that an hemangioma will not have an AV shunt inside in the vast majority of cases. So remember, optional sequences will be added in the so were added in our consensus statement. And by the way, all the links to the paper, to the European Society of Neuroradiology, to the endorsing societies will be added in the description, in the link description of the video. Number two, rule number two, DWI. DWI loves the brain. We use it for diagnosis of aggressive tumor and embryonal tumor versus non-embryonal tumor in pediatrics. We use for recurrence, we use for ischemia, but it does not really like the head and neck region. Why? Because head and neck region are full of artifacts. Why? Because there is air, there are vessels, there is bones, and so on and so on. So how you use DWI, you keep using these fabulous sequences in the head and neck region. Well, we use either multi-shot DWI that reduce the artifact or non-epiplanar DWI. So the first rule is that if you can, you use these two sequences. If your scan, again, flexibility means also that sometimes the scan do not have a multi-shot or a non-epi DWI available. Most of them should have, but otherwise you can still use a standard epi DWI. Is not ideal, but is acceptable, except for the temporal bone. Now, an example of a skull-based problem where the DWI is very useful is this. There is a patient with infection, a lot of enhancement around a fluid area here. What is going on? Well, this is actually pus, because the pus shows restriction, and this needs probably an operation because it's an osteomyelitis with an abscess in the apex, so it's a purulent apicitis. This can be a medical emergency, and you need to flag to the consultant. This was a multi-shot, and you can see how well the restricting area correspond to the fluid area on post-contrast FAT-SAT. But look at this. This is a non-epi DWI. Why, and these are images of the temporal bone. Why in the temporal bone you must use a non-epi DWI at all costs? Because one of the most difficult differential diagnosis to do is a cholesteatoma versus inflammation. And we know that cholesteatoma shows diffusion restriction, but we also know that this area is full of air because the mastoid are full of air. So how we solve this problem? We need to use the best diffusion, and in this case, best means less susceptible to artifacts. So you need to use an epi-DWI. This is our cholesteatoma. We have done the diagnosis. All right, so this is a very important point. Again, we try standardization, but also flexibility and disease specificity. The third rule is that the child is not a legal adult. What does it mean the child is not a legal adult? Well, the most important thing that this implies is that there are specific diseases that are typical of children. So if you are an adult neuroradiologist or a general radiologist, you may not encounter this very often, and you need to know how to act when you have a specific clinical query. And how you do act? Well, let's start with this Langerhans cell histiocytosis. Langerhans cell histiocytosis is characterized by an involvement of the skull, but also the face, petrous bone, brain, and vertebrae. So you need to image the skull full of fat around because there is a soft tissue, the face, the petrous bone full of air and fat and so on, vertebral bodies, and brain. But you also need to do in a way that is fast enough to provide a scan that is diagnostic in the daily routine. We know that we are busy, we have limited time for the scan, so we need to find a good compromise. Also note that in some cases, we shall consider a low-dose CT for the assessment of the bone. So the consensus statement stressed that the complementary role for the CT. And these are the many phases of the LCH. You can have intracranial masses, rarely. You can have diabetes insipidus, so you need to look in the brain specifically at the pituitary region, and you have neurodegenerative changes in the brain. So this is what we propose. Some specific sequences for the brain and skull, like the post-contrast FAT-SAT. Cellular region, just optional sequences if you have a doubt, and some basic sequences on the spine. So we try to look how short is this protocol, but still we try to balance in a way that in a reasonable time we have the best diagnostic scan. Okay. And this is another case, leukocoria. When you have a leukocoria in a child, you have several differentials. This is an amazing paper from Kelly Robson, and you see that the most important diagnosis is a retinoblastoma. And you need specific sequences to confirm the retinoblastoma, to distinguish retinoblastoma from other differential diagnosis, to check for the nerve invasion, and also to check for calcification and for brain invasion. So see how complicated is a retinoblastoma. We know that retinoblastoma can be a so-called trilateral retinoblastoma with brain involvement. And also we know how important is the evaluation of calcification to confirm the diagnosis, and how important is the nerve invasion. So how we do that? Well, we added sagittal oblique optic or post-contrast T1 facade along the optic nerve, very, very important. And we add some optional sequences in case you have a doubt, but also imaging of the spinal axis and images of the brain necessary to exclude metastatic disease and intracranial disease. And again, we come back to the expert. We contact the European Retinoblastoma Imaging Collaboration, and we ask them what is their work. We have the previous consensus, but it's dated back some years now. So they help us in having, and they endorsed this publication, okay? And this is again Vach Robson paper with all the differential diagnosis, Coats disease, persistent hypoplastic primary vitreous, and retinopathy of prematurity. You see how important it is that the calcified mass is only retinoblastoma. So we need this for confirming that. But you can use ultrasound and MRI. You don't need CT. CT is only for the bone, not for intraocular calcium in this case. So remember, again, complementary use of CT sometimes, but you need to know the literature, and you need to know that in this specific case, we don't need to do a CT in all children with retinoblastoma. It's actually a problem. If they have the mutation, they can develop more tumors. The last rule is keep an eye on the future and at the broader themes. We spoke about MRI standard sequences, but we also have nuclear medicine. This is a rhabdomyosarcoma. It's very important to do a PET sometimes in the staging of this patient. And depending on disease, other nuclear medicine examination. ASL perfusion, very important, although there is a lack of standardization. Look at this paper and look at this similar looking lesion in the face with completely different perfusion characteristic. High perfusion, this is a tumor, it's an hemangioma. These other two are slow flow venous malformation showing low perfusion. So take an eye on the future. This is very, very important. But remember, and this is just the last chapter of our consensus statement, that the caveat for these advanced techniques is that there is an extreme lack of standardization. So you need to take in account that probably in the future, some of these sequences will be used in a more standardized fashion, but that's not the moment. And what we plan for the future is to meet on a regular basis to try to update and update the protocols and expand the collaboration. These are some of the people that participate. This is Olivia. She was a medical student at the time of this protocol, and she did a great job. People from the European Head and Neck Society, Steve Connor and Ata are part of the British Society of Head and Neck. They are part of the ERIC group. This is the T-bone time. So a lot of Americans from pediatric and head and neck hospital, pediatric radiologists. This is the team I'm working with at Gosh, and Maria is from the European Society of Pediatric Radiology, and Sotirios, Katarina, and Sophie are part of the head and neck committee of the European Society of Neuroradiology. So it's very, very important, again, to come back to the expert and broaden the group of collaborators in order to do not miss anything, because no one of us has all the knowledge about every topic and all specific abnormalities or disease, especially in pediatrics, okay? So remember, also for other studies, very important to collaborate. So please try to use the protocols of this consensus statement, but critically share with colleagues and send feedback. Thank you very much. And these are, again, my contact information.